great pain relieving attribute. Then what we're going to do is we're going to do radial pressure wave around the tissue. So imagine we've got a really big target here, or dartboard. You call them darts here? Darts, yeah? Okay. Just want to get the lingo, right? So you've got a massive dartboard and you've got the big red spot in the middle, yeah? The way I see it is everything on the outside of the bullseye is where we want to be doing radial pressure wave. We're just going to cover all the connecting tissues that are coming into that pathology, and then right in that bullseye, that's where our focus shock wave goes. That's where we're going to use, because that's going to have the best result on our pathology. So if you start to think of it like that, let's prepare it with EMTT. Let's then do all of the interconnecting muscle, tissue, fibrous stuff that comes into where that pathology is, and then let's use the focus shock wave to really nuke that area. That's how I like to think about it. And this is a nice way to start explaining it to your patients who don't want you to start quoting Castle and Knobloch 2022 and all that other stuff, because they're not really that interested. That's our job to be, that's not very annoying, is it? That's our job to be interested in that stuff, not the patient. And if I could go backwards here what I want to point out to you is that I've got EMTT working on the Achilles tendon here, and I'm working on the patella tendon with my focus shock wave. And when I tell people that I co-treat like this, they go, I don't think you should be doing that, I'm too scared to do it, we shouldn't be doing that. Pretty much all of my patients are having at least 2 treatments at once. And sometimes I've got the focus shock wave here, and I'm busy getting into the traps with the radial stuff there, and there's all sorts of fancy stuff you can do with your feet to hold the foot in the right position, because time is money, as you'll find out, I'll talk to you about tomorrow, and I want 30-minute slots, and I want maximum bang for their buck and my buck. So as far as I'm concerned, never in my life has an athlete gone in and go, yeah, it just hurts there, that's the only place I've got pain. They come in and there's like 16 different places. I go, okay, let's narrow it down to 3. Yeah, I want you to rank them in order, and then I'm going to just work with 1, 2, and 3. So, everything starts with the foot. So the podiatrists among us would be loving hearing this, but I like to really assess this person, because what I always say about shockwave therapy and EMTT, let's just call it generically shockwave for now, is that that is going to help you fix your pathology. But there was a reason that that pathology came along in the first place, and that will usually be a biomechanical insufficiency, a reduction in strength, one-sidedness, whatever you want to see. So unless I know what it is that I'm actually treating and why the treatment needs to be done, then that person's coming back to me in a few months' time going, it's come back again, I need more shockwave. And if I just got that person on a piece of elastic that's pinging back in to my clinic all the time, that's not really that good for my reputation. And I think you build your reputation over a number of years and you can break it in seconds. So I need to know the why. And you've always got to understand the why. Why has this thing started? So I can treat your plantar fasciopathy, no problem at all. I'd say we're easily north of the 82% success rate that people like Professor Rompe have discussed. And if you're treating it really well, then I think, we're probably into the 90s in my clinic. So, why is that? And Carsten made a really good point. A scalpel, it's a pretty simple tool, it cuts stuff. But in a child's hand or in a nasty person's hand, that could be deadly. In a good surgeon's hand, that can save lives, right? So you look at the shockwave and you hear people go, oh, it's not difficult to use, I can use it in 10 seconds. I just want you to think about what results maybe you get, other people, maybe your competitors get when they're using shockwave. And when we come to do the practical sessions later, which is all going to be you getting hands-on and us watching, Elisa's basically physically going to come and tie our hands behind our back so we don't start getting involved. Think about learning the trick of the trade. Think about the scalpel and make sure you're using this correctly. Because if I treat a plantar fasciopathy, I'm pretty sure that I can make that person better. In fact, I'd be prepared to put a fair amount of money on the fact I can make that person better. But if I haven't worked out that their left sacroiliac joint is not working very well, and that's making them overload their right plantar fascia. And by the way, they've now got slight scoliosis in the lumbar spine, so they're now dropping the left shoulder, and now they're getting neck pain here because the scalene's all tightened up on the left side. If I don't look at that and fix all of that, that plantar fasciitis is coming back again and again. It's going to get worse and it's going to get worse. There's going to be more scar tissue in there. It's going to be more difficult for me to fix. So, because I want to maintain the reputation, I've got to do all this stuff to figure out the why. So, where does it all fit in? Here again, co-treating. This is a patient, so what day is it today? Saturday. I was treating this rugby player on Wednesday of this week, and I said, do you mind if I take a picture? You're not going to have many clothes on, but I won't put your face in the picture. Yeah? And so just to show that you can actually do these treatments at the same time. So what we have in our hand is a healing accelerator, 40 to 50% faster if you look at studies like Moen and Zisler and stuff like that. Athletes will want and need to train. So if you've got someone that's training all the time, and I never say to one of my runners, you can't run. I say you're a big adult, you're a big boy, big girl now. I'm not going to say you can't run. What I am going to say is, if you run on this, it's going to take X longer to heal, but that's up to you. Because the minute I say to them, don't run, what is the first, number one thing they're going to do within 10 minutes leaving my clinic? They're going to go and run. And if they then defy me in that first very moment, they're going to be defying me and lying to me for the rest of the time. So I flip it back onto them and go, sure, you can go for running. You can go running if you want. You can go and do hill reps. But I'm not going to successfully treat this Achilles tendon problem for you. And we're just going to be here for ages and actually do go running, because you're going to have to keep coming and see me for a lot longer, and I'm going to have a lot more money. So actually, I think it's a great idea. I think we should go running. Yeah? So, but if we can speed up the healing, then we can speed up their return to play, then we can get them back running. And if we give them a plan that says, I expect you to be able to do 5 minutes on, 2 minutes off, times 5 in 2 weeks. How does that sound? But if you go running in between time, that's going to be 3 minutes on, 3 minutes off in 6 weeks. Which one do you want to do? And so we give them an option, we give them plans. Yeah? Always find alternative training options. So there's no good saying you can't run, which I never do, but I've got to say, but let's go aqua jogging, let's get on the Alter G, let's do other things, let's get you moving. Because once they've got a plan they can follow, their coach is happy, they're happy, and by the way, they get better quicker. And they will never tell you they went for a run. Did you run since last week? No. The sweat, the dead gaze, where they just don't look away, just don't look away. Yeah? Pain relief is a problem. As I said before, they're going to get off. Coach, it feels great. Physio's done a great job. Let's get cracking. I'll be at the track in 5. Yeah? So they need to understand that. And as I said before, EMTT opens up the cells, radial pressure wave restores muscle function, and focus shock wave heals the pathology. That's a basic program, but stick with me. Without these modalities, athletes will potentially take 40% longer to get back on the track, which means that if you're not using this, you are much more shit than the person that is using it. Yeah? So, here's my radial pressure wave protocol. Fill your boots. I'm open with everything that I do. You can take as many pictures of that as you want. Try and get my good side if I have one. So we're going to do 500 to 1,000 warm-up shots. If they're in a lot of pain, stick the hertz up through the roof. You can go as high as 21 hertz on these machines. A TENS machine, which is designed only to reduce pain, works at 50 hertz. So 21 hertz, we're still not even halfway. So you want to get the hertz up high if the person is very, very active and painful. Then what you want to do is start with a low bar pressure, maybe 1.5, and over the phase of that warm-up, you want to start increasing the bar pressure. Because when I first did this, you went from 1.5 bar pressure for 500 shots, and then we cranked it right the way up to 2.5, and I used to say this is why it's called shockwave therapy, because every time I started the treatment phase, they went, oh, like that, because it was a massive jump. So we ramp it up nice and slowly. And then we can start to bring down the hertz, down to about 12 or 14 over the warm-up phase. So I'm bringing bar pressure up as I'm bringing hertz down, and we meet at that nice level in the middle, which should be around a 5 out of 10 on the VAS scale. And if you're working about 5 out of 10, that means you're treating the patient and then looking at what the numbers say. Because you should be playing around with those numbers there, and the patient goes, oh yeah, that's a 5 out of 10, that's comfortable. Then you go, oh, I wonder what that is, and then you look at it, rather than becoming obsessed with the numbers. And then we do 2,000 shots around there, and over the course of the 2,000 shots, your patient will get more hyperstimulation anesthesia. In other words, they'll feel it less, so then you can start to creep the pain up, as long as you're having a good conversation with them. And I say spend 40% of your time close to the pathology, and 60% of your time driving off in different directions with all the muscles that tie into it. So that's a 40-60 ratio. Move slowly, but purposefully. I saw a video and someone was moving up and down like this, and I was like, well, it's not really doing anything. So slowly and purposely, I've got an example video coming up with indent pressure. Yeah, we've got a bullet firing an applicator, and if that's going in soft tissue that's a bit bouncy, that's going to be just bouncing all over the place, and Newton's third law of equal and opposite reactions hasn't really been adhered to. So you just want a bit of indent pressure. Don't try and push it through to the other side, that's not very nice, but you want some indent pressure so you can see that the skin just moves slightly. So this is the clinic in action. So here we've got EMTT, we've got, can we play that video now? We've got the radial pressure wave. So we move slowly and purposely, and if you notice here on the quads, so I'm just moving the width of the head across each time, making sure I pick up more gel, and then I work in a transverse plane to make sure that I don't miss any of the muscle fibres. But quads will take around 4,000 shots to treat effectively at this kind of rate. And then here we are, again, shock waving and EMTT at the same time. Oh, now I'll start playing it again. So the focus shockwave protocol, okay? If you go right down to the bottom here, 75% of your time on the injury site and 25% in the immediate local area. Again, 5 out of 10 on the VAS pain scale. Move slowly but purposefully, but also maintain that perpendicular action. So you see people and their applicator is flying all over the place and the shock waves disappearing out to the side. Make sure that you stay perpendicular to the skin, so your shock waves are all entering the skin. I've gone backwards, haven't I? Thanks for telling me, guys. You've really got my back there. So, did everyone get that as soon as I just changed the slides and you're all just sat there sniggering without telling me? I'll see you in the bar later. And then we've got EMTT, which is very straightforward. 8 and 4,000 pulses. It's simple, yeah? Only about 20% of my patients will know that EMTT is on. So here's my thing. I've explained to them it's going to open up the cells. The stuff's going to get out, the other stuff's going to get in. It's going to really reset. A bit like when your old laptop starts to go slow and you press the on-off button and then you get it back into action. Suddenly the laptop's working fast again. I say that's what EMTT is doing to the cells that are trying to rebuild your body day and night. We're just going to reboot them, yeah? But you're not going to feed it. And because you're not going to feed it, you're going to think it's not working, because we all have that internal placebo button that's going, I can't feel anything. So you get a little ring of, have we got a ring of paper clips to do this demonstration with later, yeah? You get a little ring of paper clips, you make a little bracelet, and then you put it through the working EMTT machine, and fireworks just fly off everywhere. You singe a few of the hairs on your arm as well, but that just adds to the theatre and gives a nice aroma to your clinic. But that then shows them exactly the power that is available, and they go, oh, right, okay, that's going to do something, yeah, crank that on. But only about 10, 15, maybe 20% of my patients will feel EMTT. But there's a great thing you can do where you use it like a divining rod, and you wand it up and down the person's body, and I tell you, middle-aged men, they don't have to be in lycra, but middle-aged men will always have one SIJ that kicks off, yeah? Women that run, again, let's say middle-aged, one hip, anterior hip, like, oh yeah, I can really feel that. So there are little things that you can do. I've never had anyone feel it below the knee, but low back, SIJ, shoulders, and hips, if anyone's got anything going on, they will notice it there. So, combined treatment. Been going on about this for a lot. Here's my fish tank. I've only got one fish in there. We started with 7. The one deadly fish killed all the others. So it's a big fish tank with one deadly fish. I call him Ronnie Cray, the Cray twins from London. He was the mad one. But here, look, we've got EMTT on the right knee, and we've got shockwave on the left Achilles. That's really close, and my machines still have not exploded. I've been doing this for almost a year, and I promise you my machines don't explode, I still get good results. Everyone thinks that even having them in the same room is going to be a problem. Trust me, this is working all the time. Yeah? So, EMTT on the most distal body part, operate the RPW on the most proximal part, then switch, finish with shockwave on each area. Very simple. Yeah? And just to go back, my skeleton has a backwards hat on because I'm an ironic dude and obviously a clear, massive personality. There we go. So, here we've got a few foot and ankle conditions for you. So, those of you who can't work out what the picture is showing, that's plantar fasciitis. So here's my full protocol. So we've got 5 to 6 sessions of RPW to the gastrocnemius, 2,000 shots, 2.5 bar pressure, 14 hertz. I'm keeping it nice and simple. I doubt I ever actually do just that, but you know, I'm keeping it nice and simple. Focus shot wave to the most painful part of the plantar fascia, 1,500 shots, 0.05 to about 0.2. The hertz is determined by the machine, and then I put EMTT on it. And then I do 2 minutes twice a day of towel grabbing. We stretch both calf muscles. We put a Strasbourg sock on at night time for splinting. By the way, Strasbourg socks do 2 things. Have you seen the Strasbourg sock? It's like a compression stocking, and there's a piece of Velcro that comes from your big toe, folds back on itself, and Velcro's in place. So you have this thing going from knee to toe, keeping your foot in dorsiflexion. It does 2 things. It reduces the pain in your plantar fascia when you wake up in the morning, and it will stop you having sex. Also, we have a supportive insole with heel cushioning, and we do calf raises. Because, by the way, plantar fascia, you can treat it much like a tendon. So you should be loading it in the same way you should a tendon. So, Morton's neuroma. I like this because I get really great success. I've never failed with a Morton's neuroma. And you do 6 sessions of focused shock waves to neuroma via the dorsum of the foot. 1,500 shots, 0.3 to 0.25, pain dependent. Whack the EMTT on there for good measure. You sort of metatarsal dome insoles and wide toe box shoes. I do distal and proximal joint mobilizations, everything from the head of fibula right the way down to the tarsals, metatarsals, even the basic pips and dips of the foot. And they hold their big toe up in extension for long periods of time whilst they're watching the soap opera in the evening. Get really good results. And lastly here, the Achilles. Radial pressure wave to the calf muscle, standard protocol. Focus shock wave to the mid portion. Radial pressure wave to the length of the Achilles, predominantly medially. And then we do a basic loading program. Now, I'm really passionate about this loading program. I'm going to give you a better slide for this. But it really burns my toast the way everyone just goes on about eccentrics all the time. Eccentrics are a really high-level exercise that really I would only use on athletes once they've done a more appropriate graded loading program, which should start with isometrics, then go to Cook and Herman's heavy slow resistance, and only at the end, if they're really strong, should they be doing eccentrics. But I have a real problem that everyone, you know, it's become dogma that eccentrics. And when you've got people you're talking about, spontaneous issues with the Achilles tendon or the patella tendon, I'm telling you, eccentric loading for me is too heavy on someone that's got pathology, and there is a better way and a faster way to get there. So, lateral ankle sprains. This is where we're going to delve into the mind of Paul very, very briefly, because I've thought about lateral ankle sprains a lot. It's one of the most common acute injuries that comes into me with runners, and I think there's a different way of looking at it. And you guys might be way ahead of me, and you already do this, I don't know, so just entertain me for a second. It's an acute presentation, so would shockwave help? So for the first 72 hours of an acute injury, your body is bloody brilliant at helping fix itself. It's got an entire cascade of stuff going on, and it is phenomenal. And most people would say, just get out of its way and let it do it. But there's a nagging suspicion in my mind that if shockwave just seems to speed everything up or make just about most things better, if we've got that amazing cascade already going, could we not improve that a little bit? And that's my rhetorical question that we can talk about when you buy me a drink in the bar later. So, here's what we know about acute ankle sprains. You get reduced sagittal plane movement. So sagittal plane is basically all this movement in this direction. So ankle mobility, knee mobility, and hip mobility in that sagittal plane. We get increased tibialis posterior activity. If your anatomy and physiology is pants, then in a second there's going to be a picture of tibialis posterior, so don't start Googling it, keep focused on the big guy. You're also going to get reduced peroneus longus activity, same thing I just mentioned, there's going to be a picture, and you get reduced proprioception and reduced reflexes. So let's think about that just for a second. I've rolled my ankle, now I've got a muscle on one side that's suddenly overworking, I've got a muscle on the other side that's now underworking, taking a little holiday, I've got reduced nerve activity, and I've got reduced flexes. So think about reduced flexes as a reduced catch response. So I'm more likely to roll my ankle again. And there's a study that I've read that I can't find anymore, so I'm going to say it like it's like the law. But if you sprain your ankle twice in 8 months, you'll end up with chronic ankle instability, CAI. And I wish I could find it, because it sounds like a really good statement to make, doesn't it? But I can't back it up. So, but we know you don't want to sprain it again. So, we've got these musculoskeletal issues. We've got reduced proximal support. We've got reduced firing mechanism. We've got reduced proprioception, which is a nice word when you're not talking to clinicians that makes you sound really intelligent, so I use it a lot. Reduced central activity, resulting in a delay. Less functional support, increasing the risk of re-injury. So how's shockwave going to help? We know that tibialis posterior is responsible for inversion of the foot, peroneus longus is responsible for eversion. They're like stirrups of the foot, guiding the foot. So then when we're going to land, and we've got this wobbly foot, we've got a bit more pull on one side and a bit less pull on the other side, we've got an issue. And the co-activation of these muscles are going to stabilise that ankle. So how are we going to restore that and not lead to chronic ankle instability? So, historically, rehabilitation has always been around peroneus longus. We've injured the lateral ligaments, ATFL and CFL, two major lateral. When I used to teach, I used to do this fun thing with clinicians, where I used to get everyone to take their socks off and draw on their partner where they thought the ATFL, the anterior talofibular ligament, was. And you can have a room of 100 people and no one will get it right. It's really interesting because we're all treating it right and we don't know where it is. So we're going to injure those, and yet what we've done historically is say, well, if the damage is on that side, let's strengthen peroneus longus, because surely that tendon will do the job of those ligaments in some way. Well, it doesn't really work like that, because we've got overactivity of tibialis posterior and underactivity of peroneus longus. So we've got a juxtaposition. So if we know that shockwave reduces spasticity, and we know that shockwave can improve recovery of ankle sprains and muscle recovery, and it also improves peripheral nerves, they seem to be the four things we've got a problem with when we sprain our ankles. So why would we not jump to shockwave to do that? So here's my protocol. We're going to do tibialis posterior with radial pressure wave, because we just want to reduce down the pull of that muscle a little bit. We're going to do calf muscle trigger points, and later on we're going to do peroneus longus and tibialis anterior. We're going to do shockwave specifically to our ligaments to see if we can speed the healing up, and we're just going to blast the lateral ankle with our EMTT, reducing pain, reducing inflammation. So hopefully that gives you a bit of an understanding of how I use this stuff and what protocols we use. Just a few case studies, because every time I come to the States, I notice that everyone does lots and lots of anecdotal stuff, and typically in the UK we do lots and lots of sciencey stuff, so I'm just trying to bridge the gap there. So, male soccer player, 28 years with an acute groin strain. He had his clubs, when he plays soccer, so I should have, I did put soccer there for you, there we go. He had a cup game, which is outside the league, so they have a separate competition where they're trying to get a cup. And he was the striker, and he wanted to play, and I said, look, you've got a groin strain, they take forever, they're really fragile, I'll try doing some shockwave on there, see what happens. 3 weeks later he went on, he scored the winning goal, they won the cup, he didn't have any pain. I saw him in the Tesco's, which is like our big shopping store, about 3 months later, and he was already back in the new season and he had no recurrence. So I started to doubt whether my diagnosis had been any good, because that's one of those miracle things, right? Female 800-metre athlete, you saw one of my pictures before, 20 years old with medial tibial stress syndrome. Now, Moen et al. Did a study on a whole load of soldiers that had medial tibial stress syndrome, and the people that had shockwave got to 18 minutes of running far quicker than those people that didn't. So I thought, well, let's have a go with that then. Use the science, use my understanding of it. We did 3 sessions of focused shockwave over 3 weeks. She didn't have to stop running, she was pain-free in 3 weeks. We kept her training. That's the big thing about that, not the fact she's pain-free, we kept her training. Male basketball player, it wasn't MJ by the way, but it was a male basketball player, with patellar tendinopathy, 6 sessions of shockwave over 6 weeks. We enabled him to keep playing. He was pain-free at 8 weeks, but we enabled him to keep playing. That's the important thing. Male runner, 44 years, acute calf strain, 6 sessions of shockwave, running again at 3 weeks, pain-free at 6 weeks. So you have to have a little time off, and I like calf compression on little calf tears actually. And then the 800 metre Olympic runner I showed you, the one to watch out for, Oliver Dustin, he had an adductor strain. He missed 4 training sessions, but when he came back from that, that's when he did his world's fastest time, qualified for the Olympics in 2021 with the fastest time, and that was 4 weeks post-injury. And again, that's an adductor strain. I think you can, in certain areas, perform miracles with this stuff. But remember one of my first points? Be the first person to tell your patient the truth. Don't lead with this, because this is blue sky thinking. Lead with the science, but give them a bit of hope, saying, but there have been people that have done well. But this shouldn't be the basis upon which we sell this stuff. This should be really good stories that enable just to embellish around what the science is telling us. Because I, age 50, have very little in common with 32 collegiate athletes in Florida, which is what you find a lot of the research data coming through with. So me at 50, with my little dad bod, yeah, I'm going to respond differently to treatment than this, 23-year-old collegiate athlete. So we need to use science and we need to use anecdotes. So I think about 3 interconnecting circles. This is what the science says over here. This is what all my experience says over here. And a really important one, this is what the patient is asking for down here. And right in the middle is your protocol. And when you're dealing with athletes, you've got to try and drag that circle of what they want a little bit closer to the science, a little bit closer to what you want, because you are, as I said at the beginning, in charge. This is the protocol for your tendon repair. Isometrics for 2 weeks. Isometrics are 80% maximum volume contraction with no joint movement. So a very simple example is I stand on my tiptoes. Yeah? I only normally do this on Thursdays, which is high heel night for me in the UK. But we stand on tiptoes and we hold that for 45 seconds. And then we rest for 2 minutes, and then we do that 5 times. And this is only on alternate days. Why? Because it takes 36 hours for your tendon to go back into some sort of net synthesis or supercompensation. So if I do these every day, like the older Fraidson protocol, I end up making the tendon worse. And this is where educating your runners is so important, or your athletes. And they go, I'll just do more. He said this is good, I'll just do more. No, wait 36 hours. But because you don't want them to get up in the middle of the night, just say do it every other day. Then we go to heavy slow resistance, which is really easy. It's heavy and it's slow. Right? The clue is in the name. And this time you're going up for 6 seconds and then you're going down for 6 seconds. It's always under tension. You get greater collagen turnover, and this is a really, really good way of developing the tendon. This has been proven to reduce pain over 2 weeks. This, you get your great collagen turnover, still every other day, because we've got this synthesis that we need to get. And then, from 8 weeks, if they're an athlete, tell them to do eccentrics. Yeah? It's the old standard, not the gold standard. See what I did there? And here's how we put together an athlete training program, because we've got to do graded exercise program every other day. We've got to do treatment at least once a week, and then they've got to go training. They've got 2 days where they've got to be reduced down in their training because of hyperstimulation anesthesia. It just makes your brain explode, right? So what do? Oh, we have got a little pointer. So we're going to treat Monday, and that's their rest day. Tuesday morning, they're going to do 40% of their normal training load, because we've given them a plan. Tuesday afternoon, they're going to do 40% of their normal training load. Wednesday, 48 hours later, they do their full training and their first round of the graded exercise program, which is isometrics for the first 2 weeks. Then Thursday, Friday, Saturday, Sunday, they do their full training, alternate each day as to when they do their training program. And then Monday, they're back in to see you to lie about the fact that they have done it all exactly as you want them to. And then we run the route again, and I do 6 weeks of treatment. These are the people I'd like to thank. The Institute for Tissue Regeneration and Repair, Storts Medical, Cure Medics. This is how you get in touch with me. Keep it clean. I know I've had some expletives in my thing, but you know, I need to make sure that my Instagram isn't, you know, full of dick pics by the end of the weekend. So, but do get in touch, ask me any questions you want. I am available for weddings, funerals and bar mitzvahs, but ladies and gentlemen, a great audience. Thank you very, very much.